Hey, thanks for coming back to the show. As you can see on the screen with me, I have a guest, Dr. Paul Marik. I am going to be introducing him. I just wanted you to see who he is. Today is a special show. I will tell you a little bit about my background with Dr. Marik, but just to remind the listeners and also those listening on the radio, this is actually being recorded and will be on YouTube. We are going to do some graphics, so if you want to go on YouTube and find and look, you can. This is broadcast first on WSMN 1590 AM and 95.3 FM out of Nashua, New Hampshire. That is southern New Hampshire. It covers northern Boston. We go out onto the podcast world, which is Spotify, iTunes, SoundCloud, Google Play, etc. You can find this show at seanburke.net. I have over 150 other shows there, so you can go and look there. This is one of the shows I'm hoping you like enough that you'll share. There's a reason we're doing this today that we're going to get into. But I first want to tell you a bit about, well, let me just give you a little qualifiers. Number one, Dr. Marik has not paid me anything. I've paid him nothing. And none of this is medical advice, even though we're going to talk a lot about medicine. So I just wanted to get those out of the way. This is me working with Dr. Marik to try and get this information out. So my background with this gentleman that you're seeing there, first of all, just so you know, he is an intensive care unit specialist. This is Dr. Paul Marik again. He is board certified in internal medicine and critical care medicine, neurocritical care, and nutrition science. Those are all board certifications that he holds. He is currently a professor of medicine and chief of pulmonary and critical care medicine at Eastern Virginia Medical School in Norfolk, Virginia. Dr. Marik has written over 400 peer-reviewed journal articles, 50 book chapters, and authored 4 critical care books. The hospital that the medical school serves and that we'll be talking about some of the cases there is, is it Centara Norfolk General Hospital in Norfolk, Virginia. That is a level 1 trauma center there in Virginia. So that is his background. I want just to, how did I do, Doctor, first of all, before I go into how you and I know each other?
That was good.
I did all right? All right.
Good.
So about a year or so ago, a friend of mine slipped into acute sepsis, and that was in Ireland. For those of you who have listened long enough, know that I was in Ireland for a while, and I've talked about that story. Dr. Marik developed an incredible sepsis protocol that I believe saved her life. She's alive today because of it. Sepsis is a disease that kills, and especially when you get into the acute phase, usually people die. So I believe his protocol saved her life. And he and I have been in touch over the time period since that's about a year and a half ago. And recently I just reached out to him and thought, oh my gosh, I've been doing shows on COVID. Why? I got to talk to Dr. Marik and see what's going on. And he had a story to tell me, and that's what we're here to do, to tell you. So I have had experience with this gentleman. I have seen his work up close and personal, and I believe it did save my friend's life. So he has a great deal of credibility for me, but you decide for yourself as we go forward. We're going to lay out some things having to do with COVID that he's working on that I think you'll be interested in. So that's it. Now, I just want to say we should talk a little bit about sepsis here, just briefly, because I did bring it up. First of all, Dr. Marik, what is sepsis?
Yeah, so probably the best description is it's a patient, generally we talk about bacterial sepsis, is a patient who develops systemic signs and symptoms from a bacterial infection. So most patients who have sepsis, it's due to a bacteria, and the commonest is pneumonia or urinary tract infection. When it comes to viruses generally don't cause sepsis. It's a condition pretty much confined to bacteria. However, COVID's an interesting beast, and it does cause a sepsis-like syndrome, although it's not sepsis.
Okay.
So in essence, sepsis is the person's response to a bacterial infection.
And it's the host, it's the immune system really going crazy, trying to fight off that bacteria. Is that accurate?
Yeah, and that's where there's very similar parallels between bacteria and COVID,
Okay,
because
good.
indeed the manifestations of bacterial sepsis, and Osler knew this 100 years ago, was not the bacteria per se, but the host response to the bacteria.
And who's
And
that you're
as with
quote? Who's that you're talking about?
William Osler, who's considered the father of medicine, he noted this in his writings over 100 years ago when we didn't really understand stuff, but he was kind of astute enough to pick that up. And as it so happens, COVID is very similar in that respect to bacterial infection.
Okay, so and we're going to get to that for sure. How you transitioned over to handling COVID. Your sepsis protocol, and your experience handling critical care patients. Give us a little background on that, and your. Also, I want to hear about the success with handling
Yeah.
sepsis.
Yeah, so basically the protocol is it's called HAT therapy, HAT. The acronym, the H stands for hydrocortisone, the A stands for ascorbic acid or vitamin C, and the T is thiamine. So the reported mortality for severe sepsis and septic shock runs somewhere between 25 and maybe 40%, just as a background. So we've treated about 1,600 patients with severe sepsis and septic shock at our facility, and our mortality is probably around 5%. So we believe that if used early and used appropriately, it reduces mortality.
So, normal mortality is what, and your mortality is what?
So it's probably, depending on how sick you are, probably between 25 and 40% in advanced countries. In when resource poor countries, it's maybe up to 60%. So it's a really bad disease.
And you're finding through your protocol that you've been using, it's down to 5% mortality. Is that what you said?
So yeah, in our hands. Unfortunately, much like our COVID protocol, people are unwilling to accept that. And particularly for sepsis, they use it really late. So there was a study out of Australia in which they treated patients remarkably late. And sepsis is a time-sensitive disease. I mean, you've got to treat patients early and aggressively. So we know that with antibiotics, you give antibiotics early. With this HAT therapy, you do it early. So there was an enormous delay in institution of this therapy, and the exact time we don't know because they won't really tell us. But we think it's in excess of 24 hours of coming to hospital. So it's kind of absurd. So in a way, it was a study which we think was designed to fail. And because of that, people kind of poo-poo our therapy. They say, well, you see, this failed, so it doesn't work.
Yeah, it's like let's test a car with flat tires. Oh, this car doesn't work. I've learned over time when you have these studies, if you want to rig the study to not to fail, you can, because you're not following the exact protocol of what it's actually supposed to be used for.
Yeah, and yeah, absolutely. I mean, you have to do it with the intent to make it succeed, and you have to be aggressive in following the protocol.
So just because we're going to talk about this a little later, the protocol you have for sepsis, expensive, really designer drugs. What is it? Simple?
Yeah, so it's exceedingly cheap. It's corticosteroids, um, vitamin C, and thiamine. So, obviously in the US, people jack up the pharmacy, even the generic pharmacies jack up the price. But I know that in Europe and in places like India and China and Africa, the vial of vitamin C costs $1. And with that, you can treat a whole handful of patients.
Wow.
So we're really talking about very cheap, inexpensive therapies.
Okay, so doctor, if you tell the listeners, just give us, since I read off your background, but you're in a teaching hospital, is that right? Give us a little idea of what you're doing in
Yeah,
life,
so
not just with COVID, just as a doctor. Give us a little feel of that.
yeah, so I'm an intensivist, so I look after patients in the ICU. So that's where I practice. So these are the sickest patients in the hospital. These are people that are on mechanical ventilators or patients in shock, patients with severe infections that are at high risk of dying. And that's the environment that we work in. It's very much based on physiology, understanding patients' deranged physiology, and manipulating the physiology to improve patient outcome. So it's very dynamic, it's very interactive, and obviously the patients are sick, but many of them do well.
How long have you been with Eastern Virginia Medical School?
It's over 10 years now.
Okay, good. And did I have it right that the hospital you all treat there is Centara Norfolk General Hospital? Is that right?
Yeah, so it's a tertiary or quaternary hospital that serves Hampton Roads, it serves a population of about 1.8 million people. So it's a busy hospital.
Okay, good enough. And I want to remind listeners, if you have would like to email me at heysean@seanburke.net, that's how you reach me. And if you have any questions, when you hear this, it'll be too late, but you can always send me questions for Dr. Marik. Maybe at the end, I'm going to give you a website where you can also reach him. So, all right, doctor, let's, that was the precursor. I wanted people to understand who you were, a little bit about how you and I know each other. So let's get into COVID. I contacted you the other day and received a very strong response back from you. Frustration, and we'll get into that. But first, I want to get into, let's just start with COVID. And I remember asking you over the phone, is COVID real? So we have a lot, and I'm not trying to dissuade all the rumors out there. We're not going to go into that on this show. We're really trying to hammer away at facts on this show. But let's just start with, is COVID real? Is this COVID-19 a real thing?
Yes, I think that's a really important point. This is a bad disease. There's absolutely no question of doubt. People have dismissed this as the flu or like influenza. This is a really bad disease. It's a really bad disease, and it kills people. And not only does it kill them, it has enormous long-term consequences. So this is a very serious disease that we really have to take extremely seriously. And clearly at the moment, things are completely out of control. This is a very dangerous disease. It's a very smart virus that wreaks havoc on the host. And we have to really be respectful of this virus and take it really seriously.
Okay, fair enough. So that just gets the whistle wetted here, guys, because we're going to walk through some different graphs, and he's going to have a lot of time to get pumped up, because once I get him started, we won't be able to shut him off. And I don't want to get him too riled up because it gets crazy. He is frustrated because one of the reasons we're doing the show is to let you know the protocol that they're using at this hospital and the results that they're getting, and the fact that it's not being broadly used across the country. So first thing I want to do, we're going to do some screen sharing on this show today. These are numbers that you gave me. I wanted the listeners to be able to see this, the viewers, I guess. Again, if you're listening on the radio or podcast, this is available at YouTube. And also, if you're a subscriber to my show, and you can subscribe at seanburke.net, I'm going to include a lot of these. I'm going to include a place to download a lot of documents, and also a link to the website that you can find out more about this. So if you can look here, walk us through this, Doctor, from the early June and now here we are in July, what these numbers mean.
Yeah. So, we had the advantage of seeing what happened in China, and then what happened in Italy, and then what happened in New York City. So, and by that time, we had a pretty good idea about this virus and what it does. So we started getting cases in the middle of March, and at that time we were absolutely ready. The hospital was ready, and we had a protocol in place to attack this disease. And it's very much similar to the protocol we have now. So the core protocol hasn't changed. We've tweaked it as more evidence has come about and refined the protocol, but it's essentially the same. So we were ready.
Yeah, and we'll go into detail on that protocol coming up here for sure for everybody listening.
So basically, if you look at the world, and the average hospital mortality in first world countries is around 24%. So 24% of people who come to hospital with COVID die. We know that from New York City, the mortality in the ICU on a ventilator was 88%. So 88% of people who landed up on a ventilator in New York City died. So these are just really our data, and maybe it doesn't do justice to how bad this disease is, because it's a really bad disease, and we work really hard to save these people's lives. But what it shows is our hospital mortality is 6.6%, which is exceedingly low.
Yeah,
Most importantly, we
Yep.
don't have people who are stuck on ventilators forever. So that's a big problem in New York, is that, as we'll see, if you don't treat these patients early aggressively, they get significant lung damage, they get lung injury, they get permanent fibrotic lungs and can never get off the ventilator. So we have not had that experience. We treat these people aggressively, and almost all of those patients get off the ventilator pretty soon. And in fact, we've not had a single patient who's died on the ventilator. The patients who've died are patients with really very serious comorbidities who died once they were taken off the ventilator because of their underlying comorbidities.
And comorbidities, for those not understanding medical speak.
So a lot of really sick people get COVID. So, healthy people get it, but those who are vulnerable are at greatest risk. So we're talking about, patients in their 80s with severe liver disease, patients with severe pulmonary disease, patients with severe cardiac failure. So these were really sick people who just happened to get COVID, which pushed them over the edge.
Right.
And so what I say is they died with COVID rather than specifically from COVID. So obviously, the experts are going to say that that's nonsense. But what I'm really saying is these are really sick people. These are people who had severe, significant underlying disease.
So if you have, let's just talk about that for a second. If you have a severe heart condition, you also get COVID, and you come into the hospital and you die of a heart attack or some heart related illness, you can tell that as a doctor, I would think, versus it's COVID, right?
Yeah, so your death certificate will say COVID. So it's, so you have to report that the patient had COVID, but generally on the death certificate, you would then put, liver failure, cardiac failure, as well as COVID. Okay. The problem is when people look at the data, they can't really tell what the prime cause of death was. And if COVID's on the death certificate, they're going to assume you died of COVID.
So when we see numbers out there by the CDC and whatnot, those COVID numbers are people that had, and we're talking about deaths now, those COVID numbers show those people had COVID when they died, but they also, we don't know, as you said, if they potentially died from some other illness, but we're seeing the COVID numbers out there for sure.
Yeah, but what we do know, and the data is pretty clear, is that the risk of dying is much higher in people over the age of 60. Patients who have, as we said, comorbidity. So if you have diabetes, you have hypertension, you have heart disease, you're obese, you have a much higher risk of dying. but it works both ways. So, I mean, you could have hypertension and be otherwise fine. I mean, you're at a low risk of dying. Or so when you get COVID, increases your risk of dying. Or you could be really have advanced disease, be bedridden, have dementia, and then get COVID and die. So it is somewhat of a spectrum.
I get that. And I also don't want to imply that any statistic coming out of the CDC saying that these people are dying from COVID, not implying that they didn't die from COVID. I'm sure, doctor, you've seen people fully die from COVID. They overwhelmed systems and away they go. It's not just these other conditions. Is that right? Can you tell the difference when it's really COVID that's causing the death?
Yeah, so I mean, COVID causes a very characteristic lung disease. And obviously, so there are otherwise healthy people or people with mild comorbidities who get COVID and they die because it completely destroys their lung. But clearly, you can understand that you could be someone who has heart disease and you get COVID, you have much less resistance and you have less ability to fight. So it's going to kill you much quicker and much easier. You have limited functional reserve.
Sure. And of course, people who have absolutely no other underlying conditions can get this and die as well. I mean, that's a reality as well.
Yeah, so there's no question. This is a really serious disease. So, we've had patients in their 30s who've had severe pulmonary disease. We had a 32-year-old who was slightly obese. That was his only risk, who had severe disease. So this is no joke. This is a really serious disease.
All right, fair enough. Yeah, go ahead.
The other thing about it is that, we've had a few healthcare workers who got it, and speaking to them, they say, you know what, it's like 2 months and I'm not back to where I was before. I get tired and fatigued and can't do what I used to do. I get headaches. I got muscle aches. So, this is not like influenza. You get the influenza and you get better. These people have persistent and ongoing symptoms, even those who so-called recover.
Interesting. All right. So I'm going to get rid of this graph. I just want the viewers to look at it again. Per the state of Virginia, you can go to the COVID map per the state of Virginia, look up how many hospitalized and how many dead. And I just listed a few that you can compare to what they're doing at the hospital where Dr. Marik is at. You can see as high as 37% mortality in Chesterfield, Virginia Beach, 24%. And we go back up here early into June, 6.6% mortality, and now 6.1. The reason I'm showing these, the reason we're doing this, guys, is because we're going to walk forward and show you what the heck COVID is and what the protocol Dr. Marik is using. Because we need it to be used across the country because it is cutting down. You look right here, 6.1% mortality versus 37, 28, 22, 24. And as Dr. Marik said, in New York at the time, it was around in the 20s, I think you said. So this is important information. That's why we're sharing this right here. Okay, so we got that. And I want to go through also, doctor, there's another I want to share here is the factors leading. You spoke a bit about the factors leading to COVID-19. So let me pull this up. I don't want to spend too much time on it, but I think it's important for people to understand. You've covered quite a few of these. And just for the people viewing, there's definitely some medical terminology here. I didn't clean this up for the layman. And this is going to be something I'll include as a download if you get my emails after the show. So let's see, doctor. We walked through age. I'm interested in, you have here vitamin D status. I've heard that before. Can you talk to us a bit about that?
Yeah, so I think there are a number of modifiable risk factors that increase people's risk of developing COVID and developing severe disease. So vitamin D is a very interesting hormone and has enormous immunological properties. In fact, vitamin D is activated in the lung and has an enormous role in protecting what we call type 2 alveolar pneumocytes. So the cells that line the lung actually activate vitamin D and use vitamin D for protection, and has an enormous role in preventing the cytokine storm, which we'll talk about, and in modulating inflammation. So what we've discovered is that people who lived in high latitudes, so that's live quite north, and get less sunshine, particularly in winter, have a lower vitamin D status. And what's been discovered is that those countries and districts and states that are more north and where the population has a much higher risk of vitamin D insufficiency have a much higher death rate from COVID. So there seems to be a very striking link between vitamin D status and the risk of death. And we should note that elderly people don't make vitamin D as well as younger people. And moreover, many people, elderly people in chronic care facilities don't get out, don't get in the sun, don't go to the beach. So they're profoundly vitamin D deficient. The other thing is we know African Americans, Latinos, those people of color have a much higher risk of dying. These people also are vitamin D deficient because the pigment in the skin prevents vitamin D activation. So that may be one of the reasons, it's not probably the only reason, but one of the reasons why people of color have a much higher risk of dying of COVID.
Interesting. For those listeners who know and listen to, Dr. Gundry was on my show. I had him some time ago. He is, and you can go back to seanburke.net and find that show. He's a very big proponent of vitamin D. Vitamin D has had a bad rap over the years. There was a study years ago that really showed that it was dangerous, and that study was later proven to be incorrect. And there's unfortunately too few people take vitamin D. I'm one that does, but it seems like our government should now be saying, everybody get out there and we're going to go over some of the things you can take before you even have it, but vitamin D, it seems like the government should be pushing vitamin D, in my opinion. Any
I think
thoughts on that?
Oh, without question, but particularly those who are at most risk. So, people in chronic care facilities, in rehab facilities, elderly people, oh my goodness, they need to be taking vitamin D. 4,000 units a day. It's can be life-saving.
Good. So we'll get into more of that. Okay, Doctor, CV19, let's walk through. We're going to do a couple of graphics here in a second, but just before we get to that, give us an overview, because just me talking to you, I learned a lot that it's not just one thing. It progresses into other things. So what is CV19?
Yeah, so obviously the virus is a coronavirus. It's an RNA virus that has a large RNA, and it has a very unusual coat. So the thing about this virus, as opposed to SARS virus, is it's highly infectious, and it replicates and divides enormously in the nasopharynx. So this is your nose, and it reaches really high proportions. Now, what happens is patients who get exposed to coronavirus there are a number of different routes they can follow, which is really important to understand. So some people get the virus, it replicates actively in the back of their nose, but the immune system is such that they can then kill the virus and it goes away. And probably it's related to age, genotype, and a number of factors. So those are the asymptomatic people. But the important thing is that these people have high viral loads, and just by speaking and talking, they can cause droplet spread of the virus. So that's why it's so important that people wear masks, because that's the prime mode of transmission, is asymptomatic people who have this enormous viral load in the back of their nose, who are then spurting out all these viruses. Now, most of them, maybe 50, 60% are asymptomatic. We don't know exactly. Then what happens is a percentage of patients will develop what we call the symptomatic phase. So this is much like influenza. So the incubation period, the average is 5 days. On average, can be up to about 14 days, but usually 5 days. And then what happens is patients develop the symptomatic phase, which is much like influenza. They develop headache, fever, they may have a cough, they have altered smell, they have body aches, and they feel really awful. Some people are completely wiped out. They're just completely exhausted. And this is the symptomatic phase. And then what happens is the symptomatic phase kind of starts to get better, maybe by 6 or 7 days. Now, what can then happen is people can then recover, although they still can have mild symptoms, or it can progress to the pulmonary phase. And that usually happens after at about day 10, or once patients have had symptoms for about 5 days. And this is an absolute critical thing to understand, because this is when you get into trouble and you die. So you go through the incubation period, you then go through the symptomatic period, which you'll either recover, or what happens is the virus then goes down into the lung and causes this profound pulmonary phase. So it's a predictable progression. So patients can actually improve a little bit and then their lungs get involved. And it's at this time that it causes significant injury to the lung. What happens is it's actually not the virus itself which is damaging the lung, but the remnants of the virus generate an intense inflammation. Now, this is where the analogy with sepsis comes in. So it develops an intense inflammatory response, which we call the cytokine storm. And cytokines are inflammatory proteins. So the body develops this severe inflammation. And it's the inflammation which then damages the lung. And if you don't control the inflammation, it just progresses to the point that the inflammation then damages the lung. You get irreversible fibrosis and scarring, and there's just no way out. So that's why it's really important that patients realize that once you start going into the pulmonary phase, that's when you need to go to hospital and you need aggressive treatment.
Okay, good. That's a good overview. So this is the stages. This is important. I wanted him to talk you first through it, listeners. And now I want him to walk through it, because I learned a lot doing this with him. And I think it's important that maybe you might learn something as well. So go ahead, doctor, walk us through it again.
Yeah, so this is really what we spoke about. So here you have the incubation period. You see my cursor?
Yep, we can see it.
And it lasts about 5 days on average. And then some patients get better, whereas others go into the symptomatic phase. And you can see this is viral replication. So the virus is replicating. And you can see viral replication, i.e., you have the most amount of virus, is at about the early time you have symptoms. So when you start becoming symptomatic, you have the highest viral load and you're most infectious. This is the time you have fever, cough, headache, diarrhea, and those kind of things, and you feel awful. And then what happens with time is viral replication goes down, but then you have this very bizarre immune response. The host immune response is completely out of whack. And then what happens is you go to the early pulmonary phase and the late pulmonary phase. So the early pulmonary phase is manifest by mild hypoxemia and shortness of breath. But as we'll talk about, some patients go into this phase, have significant lung involvement, and do not have pulmonary signs. So their oxygen level in the blood is low, but yet they don't manifest signs. And this is really important. And then as the disease progresses, this progresses into the late pulmonary phase.
And what's the dotted line there, doctor?
This is really severity of illness. So you can see that this is severe, and with time it gets really bad.
So one of the things when I was talking to you before that really struck me was you can have the virus coming down and you might actually start feeling a little better, but you can potentially be really sick and continue on into some really bad stuff.
Yes, yes. So this shows it in a different way, but graphically. So basically, this is the stages excluding the incubation. So day one is when your fever starts. So you see, you start fever, and the fever can last about 12 days. This is the cough, which can last 19 days. So this is a bad disease. So even people who get over COVID have this cough for a long time. But here's the problem. After having symptoms for about 5 or 6 days, you get dyspnea, which is shortness of breath. So you can see on about day 6, you start getting shortness of breath, and that means the lung is being involved. The problem is at this time, there are some people who get lung involvement and do not have shortness of breath, and we'll talk about that. And then what happens is they hang around for a little bit, and then they go to the ICU, they land up on a ventilator, and they kind of die. So that's really
good. And for those listeners, the dotted, the striped lines are those who died, and the ones that aren't striped are the ones that lived. I asked him about that before, just so you can look at that. All right, so here's a new graphic. Go ahead and talk to us about this one.
Yeah, so I think that this kind of shows this again, that you go through the incubation phase, the symptomatic phase, and then you enter the early pulmonary phase, and then the late phase. So what this shows is that this is the viremia, or your viral load. So you see the viral load increases. Again, it's kind of maximal at the time you become symptomatic. And then what's interesting is the viral load decreases quite rapidly at the time that the inflammation increases severely,
right,
which kind of highlights the fact that the inflammatory response is not directly related to the viral load, which is important for treatment, so that antiviral therapy may have a role early, but once you enter this pulmonary phase where this intense inflammatory response, the virus is almost gone. And what you're seeing is this intense inflammatory response as a residual effect of the virus. Now, the oxygen saturation is the key piece, because obviously it's normal during the incubation period and during the symptomatic phase. But as you enter the pulmonary phase, your oxygen saturation, and this is your blood levels, your oxygen levels in the blood start to fall. And this is really the key, because this is when you need to start treatment. Now, the problem is some patients at this stage will develop pulmonary signs, will get short of breath, they'll be fatigued, they'll have severe cough, they can't get their breath. However, some patients will actually have low oxygen saturation, sometimes really low, and they actually have no pulmonary symptoms. And this is a very curious thing, and specific with COVID, and it's very dangerous. So patients can have severe pulmonary signs and yet do not manifest severe pulmonary symptoms. And this is why we recommend that patients in the symptomatic phase buy a pulse oximeter to measure their oxygen levels. And that when the oxygen levels fall, especially with walking, that means their lung is involved and they need to go to hospital.
Yeah,
so I think
that's key. Go ahead, sir.
So I think this kind of outlines the different phases: incubation, symptomatic, the early pulmonary phase. And the importance of this is if patients present late, you can see the inflammatory response at this time is completely out of control. So this is like a fire burning a house. What you want to do is you want to get to the fire early and extinguish the fire. If you wait and wait and wait, by the time the fire is out of control, it will have caused so much damage. And obviously, it's much more difficult to put out the fire. So that's why you want to intervene early and aggressively at this time period.
Right. So, but if you'd leave that up there for a second, doctor, I just want to say you and I talked about this. Can you see there we go.
Yep.
Around that point, people are still at home, right? Isn't this,
Yes.
they're still at home. So if we move a little bit forward, this is a point where you're saying to watch the oxygen levels. And just for the listeners, I have talked about this on my show before. It's a little thing that you put on the end of your finger. It costs $25 or something out of Amazon. I got one. And it is easy to operate, and it tells you right instantly. There's no pain, doesn't draw blood, goes right through your skin. It's an amazing little piece of equipment. And once that, you got to be monitoring your oxygen. And what's the number? It gets down to around 94 or so,
Yeah.
doctor?
So once it's less than 94. So the point is that these people here, you can't admit these people. Otherwise, hospitals will be overwhelmed, and they don't need to be in hospital. So these are people who are at home, have headaches and fever and whatever, but they need to monitor their oxygen saturation. Many will get better, but once they cross this threshold and the oxygen saturation starts falling, that means the lung is being involved, and that's the time they need to come to hospital and start aggressive treatment.
Yeah, and I think it's interesting. I'll tell you what I've learned, folks, is back here at this stage, this is the antiviral stage, and this is the anti-inflammation stage. So we got a couple of important stages that are happening with COVID. And I think that's got to be critical as far as treating it. And we're going to dive into that right now. So if you pull that down, doctor, let's go into your protocol. I'm going to pull it up on my side first, if you don't mind.
Sure.
Now, again, for those listeners and lay people out there, this is some pretty serious stuff. We're not going to go through every single line. Doctor doesn't have time to do that today, but I want you to have it. This is also something that's going to be in the email I send to you. You can always subscribe at seanburke.net. Over on the left, go down and subscribe, and I'm happy to send it out to you, or just email me. I'll send it to you. So if you look at the prophylaxis is what you do to build up your body prior to being infected. Is that right, doctor?
Yeah, so there are things you can do to improve your immune system so that if you're exposed to the virus, you're less likely to become symptomatic and to progress.
Good. So you can read on the screen what some of these are. Also, the doctor has put forth that part of his protocol is what you would do if you have COVID and you are now mildly symptomatic at home. That's what's key here. This is prior to and at home what you can do to help fight it. Any thoughts on this before we go to your deeper protocol, doctor?
Yes, I mean, these are the group of people that have symptoms, that are not sick enough to come to hospital, and they don't need to come to hospital. They need to isolate at home, but there are things they can do at home to reduce the risk of the disease getting worse and progressing.
Yeah, and I would just say for those listening back when Dr. Gundry was on, he would think the vitamin D levels on here are way low. That gentleman loves to jack up the vitamin D, but we're going with Dr. Marik's protocol here. All right,
Yeah,
so
that is a good question, and the optimal dose isn't known, but it's probably about 2,000 to 4,000 units a day.
Cool. Okay, so let's go on to. I'm going to pull up the next one. And now we get more into your protocol. Now, again, for the listeners, this is protocol that has resulted in, and we're going to show that again in a second. Remember one was 6.1% more morbidity.
Mortality.
What is it? Mortality? Now morbidity. Yeah, sorry, morbidity. See, I'm trying to be a layman talking to a doctor. That's what's really going on here, folks. All right, so this is what he's been doing to keep the mortality rate low at their hospital compared to everybody else. This is the information we're trying to get out. This is available on the net, and I'll give you the email address or the website address, and also you can contact me. Any doctors out there, would love to have you contact Dr. Marik. I'm sure he'd be happy to talk to you. All right, doctor. So now we have your protocol starting with your on the floor, and then you get down into this. And again, Folks, we're not going to walk through all of this, but I want you to know that this is the real deal. We have everything. He has everything laid out very specifically. It's being used. Doctor, tell us before we get into it, are there other hospitals using your protocol?
Yes, so there are a lot of hospitals that are using it. There are many physicians that are using it. Often they don't want to admit that they're using it because people frown upon them. But when you do something and it works, you're going to keep doing it. So there are hospitals that this is the standard of care. Every patient gets it. And there are some hospitals where physicians do this, but they kind of don't advertise it too much.
Why? Why wouldn't someone advertise it?
Yeah, so we'll get into why there's so much pushback, which is very curious. Do you want to talk about
before we get into that? The problem with what we're doing here is we have a certain amount of time and we have a lot of lay people. So I want to show this in case somebody wants to do any screen captures just from here. But talk to us about, in general, what the heck your protocol is.
Yeah. So as we said, this is common sense. This is not complicated. The first part of the disease is the viral replication. Then the virus essentially disappears and you progress to this intense inflammatory stage. And then what we do in the hospital and ICU phase is to give drugs which decrease the inflammation. So you can see essential treatment dampening the storm. So we have the essential pieces which really are there to decrease the profound inflammation. And it's the inflammation which damages the lung and has all the consequences. And the most important piece of this treatment is corticosteroids or steroids. And we use methylprednisolone. We believe it's the drug of choice. When we started using this, we got a lot of pushback because the WHO, the NIH, the CDC, and everybody else said don't use steroids. And that was based on erroneous data. But we knew from looking more critically at the previous data and experience that corticosteroids were absolutely critical. Recently, the recovery study was published, which validated our concept. They used dexamethasone, which is the inferior steroid, and they showed, it's really important because this is the only study ever published that has definitively shown an intervention to decrease the risk of death. So we know that corticosteroids reduce the risk of death. Yep. We think the dose they used was wrong and the drug they used was wrong. So we use methylprednisolone. That's our drug of choice. Together we add ascorbic acid, and ascorbic acid is important because it potentiates. It makes methylprednisolone work better. It's like a hand in a glove. Ascorbic acid enhances and potentiates the anti-inflammatory effect of methylprednisolone. The other important thing of ascorbic acid is ascorbic acid increases the body's host response to and makes a protein called interferon. Interferon is the host's main mechanism to kill viruses. Ascorbic acid specifically increases interferon. So what you're doing is you have this very profound anti-inflammatory cocktail, which at the same time prevents viral replication. The third piece of the cocktail is anticoagulation, because we know what happens with inflammation is it damages blood vessels and stimulates clotting. So patients get this overwhelming clotting. So in essence, you get overwhelming inflammation, overwhelming clotting, and the two together cause the profound pulmonary manifestations of COVID. And therefore, these three components together act together to address the main underlying pathophysiology of COVID. It's not a complicated concept. It's pretty simple math. 1 + 1 + 1 = 3. But for reasons that are somewhat elusive. People just think this is nonsense. They won't believe it. It's too good to be true. It's too simple. But we know it works, and my colleagues around the world who use it know it works. And patients who survive know it works.
So let's talk about Remdesivir. What's it called? Remdesivir?
Remdesivir.
Remdesivir. This layman trying to talk to a doctor. So the Remdesivir is to handle viral. It's to handle the virus. So you would need to do that. I'm not even saying you're doing it or someone else, but there's different things to handle different components. You got Remdesivir to handle virus potentially, but your focus is on the cytokine storm, the inflammation that comes after the virus starts dissipating.
Yeah.
Is that right?
So I mean, theoretically, our hope as a society would be to prevent people coming to a hospital and not getting sick. And Remdesivir is an antiviral. It acts by preventing viral replication. But obviously, from the graph, it's only going to work really early, in the very early symptomatic phase when the virus is actively replicating. Once the patient comes to hospital, viral replication is less of an issue, and Remdesivir is going to have less of an effect. So that's why the treatment of COVID is very much dependent on the stage and phase that the patient is presenting in.
All right, doctor. I want to bring up, I know we're running short on time, but I wanted to bring up this other graph that you had that talks about what to do, as far as intubation or not, because I think this is a key important aspect of this whole deal with COVID. Can you talk us through this a little bit?
So that kind of related. So what you want to do is treat them aggressively with corticosteroids and the ascorbic acid and heparin, so that the patient doesn't progress. So you prevent progression, so that you decrease the need for respiratory support. What we discovered, and this is from Italy and New York, is what they were doing is once patient entered the pulmonary phase, they would just intubate them and put them on a mechanical ventilator. They were not addressing the inflammation or the cytokine storm. They were putting on them on a ventilator. And as it so happens, the ventilator causes the disease you're trying to treat. So it's a bizarre concept, but the ventilator causes lung injury. It's called ventilator-induced lung injury. And it seems people with COVID are particularly at risk of developing ventilator-induced lung injury. So in fact, the treatment you're giving is actually harming the patient. And we know from the experience in Italy and in New York that 80 to 90% of patients who landed up on a ventilator died. And they died because no one was dealing with the inflammation, which was activating the lung and damaging the lung. And then they were putting them on a ventilator, which further damages the lung. It's obviously, if you think about it, it's completely ludicrous.
Yeah.
But that's what they were doing. And unfortunately, there are people today who still continue to do this. So what we suggest, and it's kind of common sense actually, this is not rocket science, is you give treatment to downregulate the inflammation and the storm, and at the same time you do whatever you can to prevent the patient going on a mechanical ventilator. So now there are some patients who you have no option, because if you don't, they're going to die. But you want to do whatever you can to prevent them going on a ventilator. Whereas what they were doing earlier is they weren't giving steroids, they weren't giving ascorbic acid, and they were intubating earlier. And that was really the worst kind of storm, the perfect storm for things to go catastrophically wrong. So what we do is we deal with the inflammation, and we do whatever we can to try and delay and prevent intubation.
Yeah, that's become, it seems more standard now. I want to point out to the listeners, we've talked about this proning down here, as they found that turning the patients over on their stomach is definitely helpful as well. Okay, good. So thanks for that, doctor. Now, I think we need to talk a bit about getting this information out there, you know. I think I should let you loose a little bit. This is where you came to me. We're pretty frustrated. So talk to us, if you will, about this. Why aren't every hospital in the country or the world using this? It seems like, based on the numbers you're showing in your own hospital, that it works. In other hospitals that you've told me, other doctors using it are getting the same results. So what are you running up against?
Yeah, so we put this together in the beginning of March because we had a good idea it would work. I think with time, we now know from our own experience it works. And I think from clinical studies, there's studies that show the recovery study that corticosteroids save lives. There's a study with heparin out of New York, which shows if you give heparin, you have the risk of dying. So, it's not like we're making this stuff up. This is based on really good science. It's based on a profound understanding of the disease. And it's based on clinical experience, not just myself, but a whole host of clinicians. And it is truly astonishing that we've had so much pushback. People just don't believe us. And some people think it's frankly dangerous, which is truly perplexing because our mortality data shows that it works. In fact, there was a interview on Medscape yesterday in which one of the physicians from Northwell System in New York said it was unacceptable what we did. I should add that Northwell System is the hospital that had 88% mortality in their ICU on ventilators. So it's completely perplexing. I think there are a whole number of factors. The one is physicians are very slow to adopt new things and change. I think people don't like change. This is a very bizarre disease which no one has seen before. So accepting change is difficult. Secondly, I don't think there's a good understanding of the disease. You have to understand the disease to effectively treat it. And I don't think that there's been enough emphasis by the medical community, by the task force, by people out there in explaining to patients and doctors what is actually going on. You have to understand what's going on to treat it. Thirdly, these are very inexpensive drugs. And there are executives flying around in their Lear jets who do not like this because this is very threatening to making money. So medicine and disease is a money-making enterprise. There's very little to do with improving the human condition. It has to do a lot with exploiting sick people to make money. And I think there's ample evidence with COVID that there are very strong economic factors at place that are trying to invalidate or decrease the impact that cheap drugs have while they're pushing expensive designer molecules like Remdesivir, which costs like $3,000, and others that are in the pipeline. So there are political, economic, numerous factors that have led to this terrible situation. The tragedy is people are dying needlessly. So I think that's the tragedy. And I think I have to say it again, is this is a simple, cheap, safe intervention that can save lives, and patients are dying needlessly because of physician arrogance, because of politics, because of economic factors, and also the leadership, the medical leadership. These are people who sit in ivory towers and don't actually look after sick patients. They have no idea. And I think once you actually manage these people, they are sick. They are sick as hell. I've never dealt with a disease like this in my career. They are really sick. It's a challenging disease. And I think you have to pull out all the stops. And there is this other concept that is being promulgated by the so-called ivory tower, is that every intervention has to be tested in a randomized controlled trial. While I agree randomized controlled trials have an important place, when people are dying and when you have an intervention that you think is effective, I think it is morally and ethically unacceptable to give patients placebo when you can give them an effective therapy. So you have an ethical and moral obligation to the patient in front of you to provide the best care you can for that patient. And I think giving a placebo is ethically unacceptable.
Hear, hear. Thank you for that. I know you told me this has gone to the White House at least 5 times. True?
Yeah, and I got an email yesterday that they were looking at it again. And I think every time the CDC and the NIH give pushback, they don't like it. I don't understand why. Maybe, I think the economic factors, these are very cheap drugs.
And
And
readily
nobody,
available. I mean, this is stuff that's available.
yeah, and the beauty is that, the burden of this disease it's a worldwide disease. Just look what's happening in Brazil. Brazil's can't afford expensive medications that, resource poor countries can afford these medications. And that's what we should be focusing on.
So you've mentioned it's gone to the White House a number of times, and you actually read that email to me yesterday saying, "Hey, I just got told it's being shown at the White House again." You have an organization, a coalition that's kind of put together for the listeners. It's at Covid19criticalcare.com. I'm going to put that on the screen later. Covid19 criticalcare.com. It seems to be a group of doctors you've put together that are working towards this, and one of them testified in front of Congress. Is that right?
Yeah, so we were a group of, just informally, we kind of got together. We were all critical care doctors who had previously used HAT therapy. So so we understood the physiology, we understood how it works, and we just said, hey, this is going to likely work for COVID. So, we kind of got together and informally have had discussions. Dr. Corey is from Wisconsin, and the senator from Wisconsin heard about it and asked him to testify in the Senate hearings. And he basically told the senators, the whole of Senate, basically, what I'm telling you now, and just died. Nobody seemed to be interested.
The HAT therapy, by the way, guys, earlier on in the conversation, that's the sepsis therapy that Dr. Marik had developed that other doctors are using. So they got together to put this group together. Again, that's at Covid19criticalcare.com. You also mentioned you had a long interview with the Wall Street Journal in the end when the article came out. They didn't mention the protocol. They didn't even mention you. And I went to that article that the woman had interviewed you. It had nothing to do with what you and I are talking about today. So
yeah,
I don't get that.
Yeah, I think the press has done a really bad job. I think the task force has done a bad job. The main news media have done a bad job. Maybe they're just too scared to face the truth. And I think this is a time in the recent history that the truth and the facts are really important. And it was really frustrating. She spent a lot of my time, and I went through that math protocol, explained it to her in detail, and I think she was going to publish it. And then I think her editor thought, hey, this is too controversial. We're bagging it. So she never mentioned a single word or mentioned my name. And that's part of the terrible frustration. The other thing is what happens is, which happened like with Medscape, is we do an interview, and then of course you're going to find doctors who do not like what we're saying and will say whatever they want to say to disparage us. And it's very frustrating because there was this thing in Medscape yesterday with some very unpleasant and very negative comments, which are completely unfounded and not based on science.
And again, listeners, math protocol is the COVID protocol. They call it math, just so that you understand what that is. I want to bring up again, doctor, just so we can kind of understand one more time. Guys, this is from this hospital in Norfolk. This is the results they're getting with the math protocol. And this is, to me, what's frustrating, because we're out here locked in our homes. And if we can figure out a treatment, then I don't even care if we have a lot of people getting this thing. I've talked about this before. If everybody wants to get it, fine. It's keeping the deaths down. That's the critical thing here. So we need to figure out a way of intervention when it goes into 80% of the people don't have a problem. When you get into the last 20 and then a smaller percentage go into deep trouble, that's when we need this intervention. So I need to get out of my house. I need my business to get going, and we need solutions. And this is kind of frustrating for me on my end, that we don't have more hospitals, the U.S. government, the WHO, using this kind of protocol that is showing such low mortality. So that, I mean, I can get in my soapbox for about 12 hours, Dr. Marik. This is frustrating to me. I can only imagine. I just wanted everybody to see one more time. If you look at this, this is not somebody these doctors just said, oh, this might be a good idea. They're using it in their hospitals and showing that it's working. All right. I just had to have that rant for a second. Go ahead.
So, I must agree with you. I think that the whole management has been a disaster. I think right from the beginning, and there are lots of things we need to do now. So I think if Americans knew that there was an effective treatment, they wouldn't be so fearful of coming to hospital, and they would do sensible things. And there are things they can do to reduce their risk of getting COVID, to improve the immune system so that when they get COVID, hopefully it doesn't become severe. And then if they understand when to come to hospital, if they come early, they don't land up in the ICU. So it unloads the ICU. You don't have all these patients on ventilators. We look what's happening in Texas and in Florida. These people are all on ventilators because they arrive late and they're not being treated. So it becomes a self-perpetuating disaster. And there are lots of things we can do as a society together. We need to do this together, because this is a disease of calamity. It's a calamitous disease. We need to solve this together. It has nothing to do with politics. It should have nothing to do with money. It should be doing what we can for our fellow human being to improve the condition of everyone.
Well, I don't think we can get off the air without me just asking about the vaccine, because I got to tell you, the feeling I get is there's a professional job being done to freak us all out until this darn vaccine comes out. So what's your thought on a vaccine?
Yeah, so, people have been trying for a malaria vaccine for how many years, for an HIV vaccine for how many years. There was a dengue vaccine that came out that actually killed people. So we have to be really careful. There was a coronavirus vaccine that actually caused immunity, but when the folks got coronavirus, they actually had a paradoxical hyperimmune response. So we have to be very cautious. I think we all hope there is a vaccine, but you know what? You're putting too many eggs in one basket. This may be a tooth fairy or a Mickey Mouse fantasy that may not happen. So we have to be realistic. And if there is a vaccine, it has to go through enormous testing and safety testing. So it's going to take months and months before it's actually available, by which time the pandemic will either be over or we'll all be dead. So I think putting all our eggs in the vaccine basket is very ill-conceived. And obviously there's a lot of money at stake, because companies are investing a lot of money to make a vaccine to make money.
You hate to think that money has anything to do with this, but I mean, we're living in the real world. So And just for the listeners, just so you know, yesterday, this gentleman, when I was doing the pre-interview with him, was so tired, I made him go to sleep last night. So you stayed awake. I know how hard you're working. That's the deal, how hard you're working. We appreciate it. You saved my friend's life with your sepsis protocol. If I had someone that was involved with COVID and having trouble, I would certainly be contacting you. Any last thoughts right now, doctor? Any message you want to put out there?
Yeah, well, firstly, I want to thank you, Sean, for seeing the light, because I think it's not a complicated business. And I think what we need to do is get the word out there, that this the this is a treatable disease. There are things we can do to mitigate against this virus, and we should be actively doing a whole bunch of stuff, including giving vitamin D. I mean, it's like such a low risk intervention. Giving melatonin. There's actually some really good data that people who take melatonin have a much lower risk of getting COVID. So there are very cheap interventions that we can do to prevent the disease, and once you get it, to treat the disease. And there's just been so much misinformation coming out of the media, social media, the White House. It's truly frustrating.
I feel it. I get it. And I thank you for your work and your dedication to always trying to find actually something that works. That's what we're after, is what the heck works. So thank you. And please keep going. And maybe we'll do an update as we get, we get down the road. We'll do another update with you.
Yeah, and what I should stress is, we have no vested interest. I don't own the patent on any of these drugs. I don't own the patent on oranges or vitamin C or steroids. So we're not making money out of this. And that's the whole beauty, is we're not going to make money.
Yeah, we're going to save people. All right, sir. Thank you for your time.
Thanks,
continue down the road.
Okay, stay well, hey.
Dr. Paul Marik, I've been, as soon as I talked to him, I knew we needed to get this show out there. It's important for us to understand what this disease is. I know that there's a lot of talk out there that, oh, it's not real, it's not that. But every time I talk to a doctor that's actually treating patients in an emergency situation, they are very adamant this is very real. I've known this gentleman for a while, Dr. Marik, and trust him. And if he says it's real to me. And it's interesting, their statistics. So again, if you find this compelling, please share it. We need to get this to enough people so they can try it. You can sign up at seanburke.net. Over on the left, put in your email address. I'm not doing this so you're a sign up. If you want to just email me at heysean@seanburke.net, I'll send you the link to the files. If you are a subscriber, this is what happens every week, is I send you an email with the links to the show, but also any other links. And today I will, for this show, be sending out the links to that website, which has the full protocol on it, as well as a link to files that you can download. So that's just from my side. This is what we're trying to do. Tracy Andrew-Scavage, the producer of the show, and I are here to try to bring information that's going to help us. So I think this is going to help us. I want some kind of a treatment out there that's actually going to fix people, because I got to get out of my house, folks. I got to get my business going again. We can't keep doing this forever. We need urgency. This is what I don't understand. You have a doctor who's showing you that this thing works. Every piece of the protocol is safe and it's been shown to be safe. They're just combining it into a way to reduce inflammation. So minimally try it, adjust it if you want, but come on, you can't just discard that and we're going to wait for a vaccine or some expensive drug. That's ridiculous. We've got to get going right now. This is a tragedy. We walk around like, oh, we're all doing okay because we're getting money from the government. The government can't keep giving us money. All right, see, I could get on. See, this is what can happen. I could get on my soapbox pretty fast here, and I'm not going to do that. So this airs first on WSMN 1590 AM and 95.3 FM out of Nashville, New Hampshire. Goes out on the what is it, podcast world and the SoundCloud and all that. You can find the actual links at seanburke.net. That's all I got to say. I hope you did learn something. Email me. Let me know. Email someone else. Let them know. Send them the link. We got to get this out there. Come on, let's do something about this. All right. Thanks. be well, follow those protocols, take a lot of vitamin D. Listen to Dr. Gundry's show that I have. Dr. Gundry says you take a lot of vitamin D, but also if you look back on the screen or you email me and I give you the document, you can see the things you should be taking even now just to keep your immune system up. All right, be well, take care of others. We'll talk to you next time. Bye-bye.